We'll do a change in speakers. Before we go into the satellite symposium, may I ask Simone Peschillo to come to the podium about balloon guide catheters, advancements, applications, and clinical impact.
Thank you, Iris. Good morning. I'm very happy to be here and for having me. Thank you, Nuri, for your invitation. Yes, today we are I would like to discuss with you the new technology about the balloon guiding catheter. And yes, so just a small introduction. I try to discuss about the available devices that are now on the market, the fundamental principles, and the clinical evidence that we have about this topic. We know that nowadays we have a lot of kind of techniques with stent, only aspiration, with balloon, without balloon, and so on. And also we have femoral and radial access, different kind of introducers and microcatheters, and the technique with 1 or 2 stent retrievers. But why flow arrest is so important, in my opinion? Because we know that with this device we can, with this distal balloon, we can arrest the flow and reducing the complication related to the thrombectomy, especially the clot fragmentation and in distal or new territories. Just a couple of papers about this that show how this device can reduce the risk of distal embolization, and the efficacy of thrombectomy seems to depend on thrombus composition, in particular if we are dealing with a white or a red clot. ADAPT, it seems more effective with a red clot, but balloon guiding catheter is more effective with white clot. In particular, in this paper, the authors have collected the data and have demonstrated that with white clot, aspiration is better than in red clot aspiration is better than in white clots. So we started using this device probably 7, 8, 9 years ago, but now the technology dramatically improved, and those are the most common balloon guided catheter that now are on the market. There are different sizes, measures, and provided by different companies. New technology like the Walrus is, and Bobby from Medtronic, and Embogard from Johnson & Johnson company, the brand new Paragon from Phenox, and this new very interesting device that where you can have at the same time the aspiration catheter and the occlusion made by a balloon. But as I mentioned before, what changed in these years was the technology. Flowgate, for example, is a coaxial technology that is thicker wall design. Sometimes it's a little bit stiffer, but nowadays we have new devices with this new technology, this multi-lumen technology that can allow us to have more flexible devices and that are optimized inflation space and the multiple inflation lumens. But what are the fundamental principles about this technique? Let me show you just this picture that in my opinion is very interesting, because show that two primary factors determine how much force will be required to remove a clot: the impaction force and the combined force of friction and adhesion between the thrombus and the vessel wall. So using balloon guided catheter, you can markedly reduce the pressure gradient across the clot and enhance the function of an aspiration catheter. So you can use this device not only with stand retrievers, but also with aspiration technique. And furthermore, this is a very interesting application. For example, in T-carotid occlusion, you can just inflate the balloon at the tip of the catheter and try to aspirate with a syringe, and you can reduce the volume of the clot. And this means that you can approach a smaller clot with much more easy fashion. Some clinical evidence show that additional of distal intracranial aspiration, this can not provide, does not improve the clinical outcomes. But in this another paper that summarized all the papers that were published in the last years in this meta-analysis, the authors have demonstrated that for TICI, tree result, and time to recanalization and endovascular attempts, the use of the balloon guided catheter, it's better compared to non-balloon guided catheter. And for distal emboli and symptomatic intracranial hemorrhages as well, and this support the use of these devices regardless of the retrieval method. Also for MRS score and mortality, the use of the balloon guided catheter has been demonstrated to be good. So these catheters are associated with better intraoperative technical outcomes in terms of TICI, recanalization, and MRS score. And what about the tandem strokes? Even in these cases, in this paper, the authors have demonstrated that these devices could be useful to treat this disease. And but which is the best position of or where should be positioned the catheter in the ICA? They've stated that probably the high cervical segment is the best position to achieve the best aspiration and the best and the best clinical result. And lastly, this is a technical tip, and I think it's very interesting because in case of dissection of ICA, if you occlude the vessel inflating the balloon, it's much more easier to find a way to enter, to gain the entrance in the dissection flap. And finally, I suggest you to download this paper because this is very interesting, and where the authors have compared the pros and the cons about the balloon guiding catheter. So an argument against BGC is that they are rigid and their trackability is poor. But now, as I show you, we have this new technology that allow us to have devices that are more flexible than the other. The increased risk of carotid dissection and the growing complication, but we know that the growing complications with the BCG are very rare. Against the use of this device is that may increase the risk of vasospasm, but there are no studies that support this idea. Preparation of the stent increase the procedure time, but Sometimes, contrary, the use of this device can reduce the procedure time. Some large bore aspiration catheter are not compatible. This statement could be right, but further study should allow us to better understand which is the relation using this new large bore catheter with the balloon guiding catheter. We know that balloon guiding catheter can prevent distal embolization, and another argument against BGC is that they cannot be used with radial access, but now, for example, with the walrus, you can use the radial access as well, and probably these devices are expensive. Yes, this could be a good point, but we should also compare the clinical outcome of the patient. So in conclusion, the current data can show better results using flow arrest. We have old data that compared the old technology, so probably in the next months we will have more data regarding the new technology. Yes, my suggestion is to use this new generation of balloon catheters. We have no comparison with super large bore catheters. Different results depending on how each individual device is used. What are the results with balloon inflated even when crossing the thrombus? Is it useful or not? You can use combined techniques, so this can allow you to have another tool for thrombectomy, and good results also in tandem occlusion, and as I said before, you can use it also for radial approach. So you can minimize distal emboli complication, you can increase rates of first pass efficacy, and you can pair with other techniques that we have nowadays. However, we have limited evidence that prove now the benefit of balloon guiding catheter with distal aspiration. So I'm eager to know your experience about this, but let me use just a couple of seconds of this prestigious stage just to invite you for the second edition of the SNAC. SNAC is a surgical neurovascular angiography anatomy course that will be held in Rome. We have three main learning objectives that are to master neurosurgical anatomy, interpret and apply angiographic findings, and introduce some endovascular devices. This course is special, made for young colleagues. We don't care if you are an interventional cardiologist, if you are a radiologist or neurosurgeon or vascular surgeon. This course is open to someone who wants to go more deeply in neurovascular anatomy and in angiographic findings. This is our faculty of this year with Nikolai Velinov as well. So thank you so much. I hope to see you in Rome. Thank you.
Thank you so much. Any questions? Which? Yeah.
Thank you very much. I believe this is an extremely important. Thank you for presenting this. I guess the benefit of using balloon guide catheters is so stupidly simple that no one should ask any question about it. To my eyes, the only concern is that current versions, or let's say earlier versions, are not so user-friendly. So I believe once they become user-friendly, there will be no more question. But I have one question to you regarding the combination of balloon guide catheter and aspiration. So if you do aspiration, then the success of aspiration is depending on two things. One is the pressure inside the catheter, and the second is the pressure outside of the catheter. The success of aspiration lies on that the pressure in the vessel should be significantly higher than the pressure in the catheter. So in the catheter, you have negative pressure. In the vessel, you have positive pressure. But if you inflate the balloon while aspirating, then your pressure difference is going to be much, much lower. So to my eyes, inflating the balloon during the aspiration itself, it might actually be counterproductive. Of course, once you are retrieving already, then it's absolutely advantageous. What do you think about that?
Yes, you are completely right. My suggestion is to inflate the balloon just prior to retrieve the clot. Yes.
Thank you.
I would like to make one comment regarding the carotid stenting, and you were showing the Buffalo team. So just to make it clear, it is not possible to create flow arrest from a balloon in the common carotid. You have the external carotid. We know that from previously when we looked at proximal protection systems. The Buffalo team are often using a distal filter in addition. So just that we do not create any false assumption that we would have flow arrest by inflating a balloon in the common carotid. Via the circle of Willis, there will be cross flow via the other side. But otherwise, I think very important point, but balloon guide isn't balloon guide. Many of the balloon guides so far have been so stiff, you are much more likely to cause a complication, much more difficult to get it into the vessel. Nowadays, with the newer generation, the whole play field may change. But I think we need to be careful when we combine balloon guide.
Yeah, you're right.
It's not the same.
That's why I stress the point of this brand new devices.
I really love this discussion. I've always had with the young guys this discussion whether we should go only aspirating with guiding catheter and usually 6 French other aspiration catheter, and I'm conservative, so I really love the idea behind the balloon and creating a flow arrest. And I think that there is more of a question whether you want to go fast, and as you put it, do aspiration, or whether, because now the European consensus states a patient who needs intravenous thrombolysis cannot be omitted from this, which means that we have a lot of bridging patients, which means that distal emboli actually are a problem and could be a problem if you're using only aspiration. So in my eyes, whether you would go up guns blazing using stent, aspiration in a balloon, then probably you would try to achieve everything in a single pass. Or go fast, do aspiration. Actually, that's what my young guys are also promoting, because we go fast just using an 8 French guiding catheter and 6 French aspiration, and it works. It works in most of the cases. So I'm conservative. I like the idea behind the balloon, and I really usually, let's say, go with the stent and balloon and aspiration and try single pass. Thanks.
Good. Heated discussion.
Thank you.
A very important topic, and we'll hear more about that. Thank you.